Good morning, and thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Dereniuk, and this is part 2 of the 2-part webinar series, Achieving the Triple Aim for a Triple Challenge, Pain, Weight Loss, and Incontinence. Today we will be hearing from Dr. Lynn McNicoll, who will wrap up her discussion from part 1 of this webinar series and will be available to answer participant questions. We also have Pam Heckman, who will be on to answer some questions specific to the QMs that we received from you following the first webinar. And then we'll be hearing from the folks at St. Mary's Duval Pavilion in Maine and about how they improved on their pain measures. Now, before we introduce our first speaker, I'm going to quickly review a few housekeeping items. This webinar will be recorded and the presentation will be available within a few business days. The phone lines will be on mute for the duration of the presentation. We will ask that you please do not put your line on hold. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. Please make sure to send your comments to all participants, as we will be monitoring and responding to questions and comments in chat. We will also have plenty of time for questions at the end of the presentation. Lastly, if you find that the presentation is a little cut off, please use the plus or minus icons in the top right of the presentation window to adjust your screen accordingly. So, give me a moment because I cannot move my slides forward. Here we go. All right, so now let's get underway with today's presentation. I'm happy to introduce Dr. Lynn McNicoll, who has been a consultative member of the QIN-QIO team for years and is a geriatrician by trade, practicing in both long-term care centers as well as in hospitals. Thank you for joining us, Lynn, and I'll pass the ball over to you.
Thank you, Sarah. Good morning, everyone. So I just wanted to briefly overview some of the principles that we had talked about. Sarah, how do I move? Oh, got it.
At the top, yep.
There you go, got it. So we had talked about 3 of the quality metrics, which are quite important to all of us: pain, weight loss, and incontinence. And the reasons, we talked about many of the reasons why that's important in terms of regulatory reasons, financial reasons, and of course providing person-centered care. We reviewed our data across the region, as well as comparing us to national data for the 3 metrics. As a geriatrician, I could not resist but talk about geriatric syndromes. And we talked about how risk factors are often universal for multiple geriatric syndromes. So if you address the risk factors, you will reduce the risk of a geriatric syndrome in our resident population and ultimately lead to improved long-term outcomes. I briefly mentioned about habilitation therapy and showed some of the data regarding that. And we talked about, in general, the geriatric holistic approach, which, as I mentioned, if you do individualized, multifactorial, person-centered care, you will improve on multiple metrics. And, of course, we need to properly document this, both from a nursing standpoint, but also from a physician standpoint. And then some key points that we talked about in terms of the 3 metrics. One was assessing pain in residents with dementia, and I'd love to hear more about people's thoughts and how they approach this. But if there's any indication of a presence of pain behavior, grimacing, moaning, then you might want to consider pre-medication or around-the-clock empiric trial medication, and avoiding any kind of pain-inducing behavior or movements or approach. And try to reassure residents related to fear-related behaviors. If the behavior is potentially suggestive of pain, meaning it's difficult behaviors or not necessarily classic pain behaviors, you want to make sure that their basic comforts are being met, that there might not be any other reason for discomfort, and then consider a trial of empiric analgesic medication. For nutrition, I think this is key to get all specialties involved, all disciplines involved, and this could be true for everything, but making sure that you review medications, and medications aren't potentially the cause of anorexia or weight loss. We talked about dysphagia, comfort feeding in advanced dementia patients. And if depression is an issue, mirtazapine might be the best agent, assuming they tolerate it. We also discussed the pros and cons of oral supplementation, and I'd love to hear some of the strategies that people have used. As you all know, the American Geriatric Society chose oral supplements as a Choosing Wisely campaign issue, not specifically to nursing homes, but in general they went against oral supplementation. But I think that was to highlight some of the issues around oral supplementation, that it might replace a meal as opposed to supplement a meal. And Megace and Marinol are unfortunately not beneficial in weight loss. And then in terms of incontinence, if you are certain that there is urge incontinence, the best agent might be Myrtrex, because it has the least anticholinergic properties, and so it won't cross the blood-brain barrier and affect the dementia or cause delirium. And when you have a male who has either incontinence or urinary tract infection, you might want to refer to urology or get urodynamic studies. Those are the residents that need close monitoring for urinary retention. And a reminder that cholinesterase inhibitors, which are used to treat dementia, can exacerbate incontinence, and you might want to consider stopping them, but monitor for worsening agitation and weight loss. And again, reviewing medications that could be contributing to incontinence. So a lot of that is working with your medicine providers and pharmacy specialists to help you to approach the care of these residents in a manner that is helpful to them, but a lot of the time it's getting rid of medication as opposed to adding medication. Also, some ideas that we had talked about, engaging a resident family council, having a tasting party for the food to see whether there are things that could be done better in terms of the food that's being provided from the kitchen. Targeting residents that trigger on multiple metrics, again, and the principle of geriatric syndromes and affecting risk factors across the board, and then a few other ideas that we had talked about. So I wanted to keep it nice and short and a summary of what we've already talked about, because I know that there are many questions related to the quality metrics, and I wanted to allow Pam the opportunity to talk about this. So I am transferring the ball to Pam. Pam, you can move the slides now.
Okay, can you hear me?
Yes.
Okay. I'm not sure how to do the slides.
Right up at the top.
I'm sorry?
You see that it moves, or did I only move it for myself? If you want to move it for yourself, Sarah. Actually, Pam, if you want to just give the ball to Sarah, because I don't think you have a lot of slides, right, Pam?
No, I don't think I do, and I haven't had to use this. I'm sorry.
No, I'm going to tell you right now. So if you right next to your name on the webinar, up there at the top, there's a little ball. If you click on that ball and move it to Sarah's name, a little window will pop up that says, "Do you want to make Sarah the presenter?" And you hit
Yes.
or allow or whatever it is, and then it will go back to Sarah.
Got it.
Yeah.
Okay, so surprise me with the next slide. Okay.
I have the slide is a screenshot of the Understanding the New MDS 3.0 Quality Measures Manual that Pam put together. We did include a link to that in chat, so if you want to click on that link, it'll direct you to our website with our resources page, and you'll find that manual there. And we do have a few questions that we have gotten from you folks, and so we're gonna treat this as kind of an interview Q&A session with Pam and myself. So, Pam, the first question that we have is, what is the look-back period for pain, weight loss, and bowel and bladder incontinence?
Okay. The look back for pain for both the short stay and the long stay measures is 5 days from the assessment reference date. The look back for weight loss is taking the weight within the most recent 30 days, looking back 30 days, and looking back 6 months. So those dates the weights from those time periods have to be available to the MDS coordinator in order to compare the current weight with those 2 time periods. If there's a 5% weight loss between the current weight and the weight of 1 month ago, then they will trigger if all else is in line, or if it's 10% weight loss from 6 months previously, they will trigger, unless there's exclusions. And for the bowel and bladder, it is a 7-day look back for both bowel and or bladder, and then they would trigger if the answers are specific to the triggers. And the information that I just gave you is included in the snapshots in the Understanding the New MDS 3.0 Quality Measures Manual. Pain, it would be on page 5. Weight loss is page 43. And bowel and bladder is page 41. But there's also an index so you can look it up.
Thank you, Pam. You know that manual like the back of your hand. Okay, next question. Where can I get a copy of a validated pain screen card?
We do have the pain screen card available on our website to download. The QIO in the previous contract scope of work used to distribute these pain screen cards as laminated 2-sided cards. And unfortunately, like everybody else, our budgets are different, and we are not able to provide you with the actual laminated card, but you are able to download that tool, and you can copy it and get them laminated would be my suggestion. I've had those pain screen cards used everywhere from hospitals to doctor's offices to nursing homes, to the liaison using them at the hospital to instruct incoming skilled residents the importance of those cards, to teaching families and teaching residents and staff. If you have any trouble with finding it on our website, please let one of your QI specialists know. Give me a call or send me an email.
Thank you, Pam. I can add a link to that in chat in just a moment. Pam, could you talk a little bit about the process of weighing a resident, since that can lead to a high QM for weight loss?
Yeah, this has been sort of an interesting area for me, and there's 2 approaches to the weight loss. One, Dr. McNicoll talked about and has a very good medical approach to what might be the causes of weight loss and ways to alleviate it. But I have looked at the quality measures and talked with nursing homes, and I've identified that sometimes the quality measure might be high because your process is inaccurate or has some gaps from best practice. And some examples of that are literally you would look at everything from the point of an LNA putting a resident onto a scale all the way to how it gets documented and how the person who's entering that data into the computer is doing it. An example is when the aide goes to weigh a resident, does he or she know whether or not the wheelchair, if the resident's in a wheelchair, should the wheelchair have the legs on or off? How much does the wheelchair weigh in each case? Is the cushion included in the weight? Is it the correct cushion? Should the resident have their shoes on or off consistently each time they're weighed? Should they be dressed completely or in their pajamas? Should they be weighed before or after a meal? If they are a dialysis patient, are you using the wet or dry weights consistently? Are you contacting the dialysis center and using their weights? Is there an agreement on that with you and dialysis center and the physician involved? Another piece of it is, are your scales calibrated? How often are they calibrated? And who's responsible in your facility for calibrating those scales? For residents who are weighed in bed, I understand there are some bed scales. Are those being calibrated? It's really important to look at all the little pieces that are involved in getting a resident's weight and having them weighed consistently from 1 month to the next or one weight period to the next. And sometimes there's, and quite often there's room for error in that process unless it's really well written up, a procedure is followed consistently, and all staff know to follow it. Does anybody have any questions on that?
If anyone has questions, you can ask in chat. We'll also open up the lines after our next presenter for anyone that wants to ask over the phone questions. But in the meantime, you can ask over chat. Pam, is there anything else that you wanted to cover on those QMs before we move forward?
There is a question in chat to me that wanted to know if the patient meets the exclusion for dementia, why do they flag? And I would have to look at the measure and go into detail on that, but it does talk about it in the quality measures manual. The person that asked me that, I will try to answer that question for you in chat.
Thanks, Pam. Just make sure you send it to all participants, and to the folks on the phone, make sure you send your chat questions to all participants so that we can see them and respond, and everyone is able to see the responses.
Okay.
So thank you, Pam.
Yes, and go ahead.
Oh, we're going to move on to the next speaker. Do you have something else that you wanted to talk about?
Nope, I'm all set.
All right, great. So now we're going to introduce Jessica Dagneau from St. Mary's Dewville Pavilion in Maine. Jessica, to unmute your line, press #6. We'll give you a minute to unmute your line. Again, it's #6 to unmute. And I can move along the slides for you.
Jessica, make sure you didn't also manually mute your phone. You might have to also unmute the phone itself in addition to #6.
All right, while we wait for Jessica to join the line, in chat we have a patient who lost 6 pounds in 1 day and regained 7 pounds the next day. Given the inaccuracies of weight, how are we supposed to report this in MDS? Pam, do you have an answer for that?
I can try. I'm a little unclear what the question is, but I think you should be questioning the realistic weight loss and weight gain there. unless it's expected for some medical reason, I don't know how somebody could gain that much or lose that much. So I would say that the scales are probably off, and I would calculate the scales and reevaluate the weights at that point. There's sometimes people are on a treatment plan such as a Lasix to diurese them, and that would be under a prescribed weight loss. So they wouldn't trigger for that. And as long as the physician is looking to see weight loss, then it would still be under prescribed. But if the medication is being used to maintain the resident, then you would no longer say that it's prescribed for weight loss. That's just one piece I thought I would add.
Thank you. Go ahead, Lynn.
Well, this is my question. I think this is something that I don't have any confidence in weight. I guess that's my point. And even though it's scaled, I mean, most of the time it's CNAs that do the weight, and there's no way a person lost 6 pounds and then gained 7 pounds.
Right. And Lynn, I think that's right, and I think this is where a facility, and maybe you could approach the director of nursing and just say that you really want to see what their policy or procedure is, and see if there's a way that can be improved so that you can rely on the weight, because that's just not okay that you can't get an accurate weight. And I'd be happy to work with any nursing home one-on-one if you are having an issue, or if you want to call me, I can try to help you on that. I do have a PowerPoint that I've done on this weight loss, and I think that it's in process right now of being posted to our website. So I'll talk with Morgan about that afterwards. That goes through some of the steps I went through above.
Thank you.
Thanks, Pam. Thanks, Lynn. And if we have any folks on the phone right now who have any best practices on how to keep weights accurate, if you have any policies, please feel free to share that in chat. I'm going to check in on the line again to see if we have Jessica. Jessica, to unmute your line, you need to dial #6.
Hear us now?
Yes, we can.
Hi, we're here. Can you hear us okay?
Perfect.
Awesome. So thanks for having us. My name is Jessica Dagneau. I'm an RN, and I'm in charge of quality at St. Mary's Duville, and I'm here with Marissa Varney, our director of nursing. Do you want me to...
Just let me know when you want the slide.
Okay, so you can change the slide.
Yep.
So as we all know, pain is a triggering CMS quality indicator. So you look at pain on the CASPA report, and we track on our dashboard monthly long-stay and short-stay patients. Pain does affect the 5-star CMS rating. So we started looking into what was going on. We were triggering hyperpain. We looked at patient care, and then we completed a drill down. And we will review patient care, drill down, the implementations of our findings, lessons learned, and standardization while we chat. So next slide, please. So what is a drill down? You need to look at your resources. It's important to pull your CASPA report monthly. So you can go to the CASPA report, and it's called the Resident Level Quality Measure Report. And we look at that monthly here. So not only are we pulling the snapshot of all of the live data, but we're also looking at the residents who've triggered every month. So we started reviewing all patients who triggered for pain, and then we developed a roster for those patients who were triggering high in pain, and we started having some team discussions. We looked at the patients. Are they behavioral? If they're in constant pain, do they have scheduled pain instead of pain medications instead of PRN? Are they on the right medications, or do they need something in adjunction to narcotics, like maybe ampicillin for deeper pain or Lyrica? We started brainstorming with the team, and from there we had communication to all team members of our findings of the drill down. Do you want to change the slide? So from the drill down, we started to implement some of the findings. We found that short stay and long stay both would benefit from facility-wide functional rounds weekly, that would address those who are triggering for moderate and above pain by the interdisciplinary team. So what we do every Wednesday, the medical director, the therapy manager, and other leadership members go to every unit in the house, and anyone that has triggers for moderate pain is assessed on the spot for that week. We also review all falls weekly as well when we're doing the functional rounds, and we go unit to unit and have those open discussions. Some patients, if they're alert and oriented, we engage them in the conversation to see what's going on. What was your pain at home? Is this pain, you're telling us a 7. Do you know what a 7 really is? And we read them pain descriptors. And then we also built into our electronic medical record pain screening on admission to assess prior pain levels at home, as well as other measures used at home that might help manage the pain. So although they might say they're in a 7, on admission we screen them. And what was your pain like at home? If you're in chronic pain, were you always in a 7? Did you use ice at home? Did that help? Just so that we can start having a better snapshot of what their pain was and how we're going to manage it appropriately in the facility. Next slide, please. So short stay pain. So 2 different triggering quality indicators. We started with our short stay pain. So we built these beautiful pain boards that are in all of our rehab rooms. And there's a multi-pain scale approach with visual cues. So we have the FLAC on there. We also have mild, moderate, and severe, as well as the numbers. So that way patients can correlate the numbers to the descriptor to the actual pain and give them a visual cue. We have a next dose box to alleviate the anxiety. And we do patient education and assurance. So just because they tell us they're in a 10 out of 10, we educate them, you can tell us you're in a 4, and we're still going to medicate you appropriately. So it's that kind of patient education. And we also read to them the descriptors. So if they say, I'm in a 10 out of 10, but they don't look like they're in bone-crushing, you could go to the emergency room kind of pain, we educate them on, this is what a 10 is by definition, this is what a 5 is, and we've done that with all of our patients. We've also worked hard with patients coming from other facilities, whether it's an acute or another facility, that we're having the proper RXs arrive with the patient. So quicker administration upon arrival. We found that there was a lag time if the patient did not arrive with the right narcotic, and that would indicate a higher pain score on admission. And by working with that, we were able to medicate our patients more appropriately. And we're also sending facilities to pre-medicate patients prior to arrival. So that way, if we have an orthopedic patient coming, even though the hospital is literally across the street, we want them pre-medicated so that they're comfortable when they're arriving here, they're more relaxed, there's less anxiety about when they're going to get their next pain dose. Next slide, please. So some lessons learned. Standardization is key. That's my favorite word is standardization. Our MDS coordinators complete the pain interview in the ARD window using the scripted pain interview, and they also do a PHQ-9. So we've then given education. The MDS coordinators have provided education to all of our nurses about what the PHQ-9 is and pain interviews. All staff have been educated on the pain interviews, especially for those important staff interviews. So when our patients cannot speak verbally, our staff have to interview another staff member about those pain scores. So we've worked with staff to develop best practices. And then it's a standardized approach to pain. We are educating our patients as well. So it's important for our patients to know what we're doing and understanding what a 10 is, what a 5 is, what are their goals, and how realistic is it to be pain-free if they are always in chronic pain. Next slide, please. Some lessons learned. Of course, there's always lessons learned. So improve communications with sending facilities for patients to arrive pre-medicated and with proper scripts to decrease wait time. So this is, of course, a process and a problem anywhere you go. So it's really working with the case management team, the nurses prior to receiving reports, and really building those relationships. That has been key. Avoiding complacency. So although we started to see our pain scores decrease on the CASPA report, we don't want to ever become complacent, so that is still going to be on our dashboard moving forward. You need to engage all staff. So through leadership rounding, education in services, posted memos, and email blasts, we keep all of our staff engaged for proper pain management for all of our patients. We also are big fans of the Interact tools, and we use stop and watches. So this way, the MDS coordinators can fill it out if they're doing the pain score and they see someone is in constant pain or has a triggering number. And every month we pull a winner of the Interact, Stop, and Watch tools that are turned in and reviewed, and we also track it monthly in our quality program. Next slide, please. So year-to-date findings. So it's pretty interesting to see, once we started doing some work in March and April and doing the drill downs, how successful we've been in keeping our pain under a triggering QI. We did have a little uptick in December for our long-stay patients, and when we did drill down, we saw many of them were behavioral patients. Next slide. So to recap, we've done drill downs. It's important to know what tools are available and to educate not only your staff, but also the patients on what pain management is and how we can all work together. So thank you for your time. And if you have any other questions, we are here to answer them.
Thank you, Jessica. Your team is doing really great things, and we really appreciate your sharing with the group today. We're going to address questions now. Morgan, can you please tell participants how they can ask a question?
Sure. If you have a question, all you have to do is press #6 on your phone to unmute your line, and then just make sure you didn't manually mute your phone as well. Again, it's #6.
Also, you can submit a question using the chat panel on the right-hand side of your screen. We'll check chat first to see if we have any questions. From Jennifer, she writes, to each facility, as we are all a bit different, what are social workers responsible for with care planning, MDS interviews, etc.? Jessica, do you want to answer that question?
Sure. So social workers are a very important piece of the puzzle. Our social worker team rounds on the units, and when they're doing the IVT meetings, they do address pain. All departments in our facility, from the beauticians to the therapists, social workers, facility and maintenance departments, have been trained on the Stop and Watch tools. They are in standardized locations on all units, and all directors of departments have them. So this is a good way, if they're in a room and someone says they're in pain, they can use this as a communication tool.
And that is also a part of the conversation in team meetings, to see if we are managing the patient's goal of pain or pain reduction, or if they have any questions through the physician in regards to their pain regimen.
Great, thank you. We have another question in chat. Who do you find to be the best person to complete the pain interview? The MDS coordinator or the treating nurse? Jessica or Pam, do either of you or both of you want to address that one?
So in our facility at Duville, the MDS coordinators all address the pain for the pain interviews for the MDS.
Hi, this is Pam. I've seen in the different nursing homes, I've seen different approaches, and I think one of the keys is whether or not the resident is responding well to someone that comes in who's the MDS coordinator who they might not know very well and think they have to answer in a certain way, as opposed to the treating nurse who may or may not know how best to complete the pain interview. So I don't think it necessarily would have to be one person or the other, but I think the key is making sure that their approach is such that the resident feels comfortable in giving an honest answer. I'd also encourage nursing homes to look at using the questions on the MDS throughout the year, not just at the time of the MDS assessment, so that the residents become familiar with the questions and aren't intimidated. And if they're familiar and you don't think that they totally understand it, when you're not in the assessment reference date window, you can educate them. If you go in and ask them the specific question, how much pain have you had in the last 5 days, or whatever the wording is, if you get an answer that you don't think makes sense, you can use the tools that you have, use the pain screening tool with the definitions, and sit down and really talk with them to see if that really is the level of pain they're having. I also say that if the MDS coordinator or the assessing nurse gets an answer at the time of the MDS assessment that doesn't make sense to the record and the knowledge that you have of that resident's pain level, if it's a surprise to you, then that should be a signal to you that something's off. I mean, if they're having level 10 pain on the day you do the assessment, and every other day in the last 90 days they've had, level 1 or 2 pain at the most, then that's something's wrong. So even while we have to take the answer from the resident, the pain is what the resident says it is, it's possible that the resident doesn't understand the pain scale, and I've seen that firsthand with my own family.
Thank you, Pam. We have another question. Who are the members of the drill down team? I believe that's a question for you again, Jessica.
So I pull it individually, and then I start going through the roster kind of with a highlighter. I look at who's triggering for long stay, who's triggering for short stay, and then we bring it to the leadership team and all nurse managers as well as our clinical resource nurses to start talking about these patients are triggering. We populate a list. Does anyone have any ideas on what's going on? And we also engage the MDS coordinators who might have done the assessment, and they could say, oh, this person triggered for constant all the time, and this is what they did after the fact.
Great. We have another question for you. At St. Mary's, how successful are you at making sure a resident is pre-medicated prior to transfer from the hospital? Also, how is that communicated last minute with nurse-to-nurse sign-out can happen up to a few hours before transfer?
We work to build relationships with all of the other all the acute facilities, so it's kind of a standing expectation. And as a nurse, you're sending a patient, you would hope to pre-medicate them for their control. It's a best practice, kind of. We also make sure that when we're doing nurse-to-nurse report, we ask when they're last of medication was.
Great, thank you. And then we have a follow-up question to the one about the drill down team, again from Rita. Also, who are the members participating in the functional rounds that you have?
So were you going to pick her up?
So the members, again, are medical director, the rehab manager, leadership including the administrator, director of nursing, the assistant director of nursing, nurse managers, and social workers, as well as nurses on the floor taking care of that patient.
Okay. We're leaving there at 4 to go pick Rowan up, and then you'll be back.
Great, thank you.
Yeah.
Just a heads up, if you want to check your phone, make sure you are on mute. We can hear some background noise. Do you have anybody that's on the line that has a question?
Okay, well, make sure, because I'll probably have to see her, right, before she gets home.
Hi, Sarah. I'm still hearing background noise. Someone does have their phone off, I believe.
Yeah. Hi, make sure you put your phone on mute. We can hear your conversation. Did somebody unmute their line because they wanted to ask a question? Okay, so we don't have any additional questions in chat. Does anyone else have a question? Throw it into chat or join the line. To unmute your line again, it's #6. While we wait to see if there's anyone else that has questions in chat or on the line, I just have a few last announcements before we end. I have contact information for all of the state leads on this slide, so feel free to reach out to your QIN-QIO state lead. You will be receiving a follow-up email with a link to a very brief survey about today's webinar. We ask that you please complete it. This is very important because your feedback can really help us improve these sessions and provide you with meaningful programs in the future. Also, within the next few business days, we'll be sending out an email to everyone that contains the link to both today's presentation and a recording of the webinar. Also, the New England QIN-QIO is now on social media, so check us out on Facebook, LinkedIn, and YouTube. We can provide you with links to our social media accounts and chat, but just look us up. It's the New England QIN-QIO. Also, we are having a contest, and we'll be giving away to one lucky winner a copy of the Staff Stability Toolkit. It's a $75 value. So to enter this contest, go on to Facebook, look us up, and like us. The winner will be announced on March 16th, so like us before then. We have one more question in chat before we end. Which tool do you use to describe each pain level to the residents? Is there one available for all homes to use? And did you develop your own descriptions? We actually have the pain screening tool on our website. There is a link to that in chat, earlier in chat. So if you need to access the pain screening tool, the link is on in chat as well, and we can certainly include that in the email that we send out in a couple of days. So again,
Sarah, I would just add that a few years ago, the QIO did some research and was able to identify the different levels of pain with descriptors, and that's what side 2 of our pain screen card has on it. I have seen other versions of that online, and they're pretty much almost exact word for word explanations. So it's an option. It's not mandated, but it has been very successful when nursing homes have used those definitions. And we didn't mention the pain ad tool, but for people who are unable to answer the pain questions, the pain ad tool is one of the validated pain screen tools that staff can use. And it does come with definitions. If anybody has any questions about it, you can either Google pain ad or you can contact me, and I'll be glad to send you everything I have on it. But it's a very good tool, and it does work on the 0 to 10 scale so that it correlates.
And we also have a copy of that pain ad tool on the website. Thank you so much, Pam. And thank you all again for joining. Have a great rest of your day.
Thanks, Sarah.
Bye, thank you.